I would now like to introduce our speakers for today's webinar. Dr. Carol Ireton-Jones received her PhD and master's degree in nutrition from Texas Women's University. Her undergraduate degree in nutrition and dietetics came from Texas Tech University, where she also received her clinical training. She developed the Ireton-Jones equations for estimating energy requirements in hospitalized patients, and these are widely used nationally and internationally. She received the Distinguished Nutrition Support Dietitian Service Award from FASPEN in January 2018. She is a consultant speaker and has lectured extensively nationally and internationally on a variety of nutrition topics. She has authored 4 books and numerous book chapters and peer-reviewed papers and received many honors and awards. Balancing both evidence-based nutrition with sensible and practical applications is her strong point. Dr. Mohammed Baloney is an internal medicine physician, obesity specialist, healthcare technologist and strategist, and entrepreneur. He applies user-centric design to change healthcare interactions and workflows, A/B testing digital and service prototypes within the healthcare space to redefine the patient experience or to implement new practices to improve employee and physician workflow and satisfaction. He's used a varying combination of market academic research, evidence-based medicine, user interviews, finance, and data to develop strategic plans for clinical transformation. His interests include using mobile as a platform for persuasion to make clinical practices or programs more effective, efficient, and scalable. When people ask him what he does, he often says, "We help people manage their weight, but more importantly, we help them see past their weight." Jody Horstman is an adult gerontological certified nurse practitioner. She is a past member of the Obesity Medicine Association and currently secretary of the Iowa Obesity Society. She has worked for Iowa weight loss specialists as a medical weight management provider for the last 3.5 years. Her program offers both medical and surgical options for weight loss. KORR Technologies' indirect calorimetry system is an invaluable tool used daily in her practice for assessment of resting metabolic rates. Most all of her patients are grateful to gain knowledge about their metabolism, and it is an important tool in treatment selection based on individual results. Lastly, Dr. Gerald Morris of AMG Medical is a native of a beautiful island of Jamaica and grew up on the island of St. Lucia. Dr. Morris is certified by the American Board of Internal Medicine. He completed his undergraduate studies at St. George's University in Grenada, West Indies, then went on to receive his medical degree and master's in public health at the same university, graduating in 2007. He completed his internal medicine residency at the Seton Hall University program at St. Michael's Medical Center in Newark, New Jersey. Dr. Morris moved to Tucson, Arizona 7 years ago and has been practicing outpatient internal medicine. Dr. Morris's clinical focus includes primary prevention and management of complex chronic medical conditions for adults. When he's not in the office, Dr. Morris's interests include martial arts. He's an avid sports enthusiast and enjoys spending time with his family whenever possible. He has 2 sons and has been married to Dr. Amanda Backus Morris for more than 10 years. Now I will turn it over to Allie to begin the webinar.
Hi, everyone, and welcome. I'm Allie Law, and this is Julie Kofed. We come from a company called KORR Medical Technologies. It's a company that manufactures resting metabolic rate equipment. And we wanted to create a conversation today about RMR in practice. So how to implement it, why it's important. And so what we've done is we've gathered together a panel of very qualified doctors and nurse practitioners who have practiced it and have had a lot of success with it to create a conversation about how this all works and the best way to apply it. And hopefully, if you're listening and you're considering getting equipment, or you already have equipment and you just have questions about how to do this testing and why it's important, hopefully this will answer some of your questions. And like Tim said, if you have any questions as we're talking, go ahead and put them in the Q&A section. We will be happy to answer them at the end. First of all, I want to thank all of our panelists for being here. We really appreciate you. We really appreciate your time. I know that you've taken time out of your schedules some of you have come straight from seeing patients. So we really appreciate you taking this time to come and talk to us. To kind of create a foundation for what we're going to talk about, I was wondering if we could start with each of you telling us a little bit about your practice, what you do, what's your specialty, so that we kind of know where you all are coming from. Let's start with, I'll go down the list on my screen. Carol, you're first on my screen.
All right. Well, thank you. And it's a pleasure to be here with you and with my esteemed colleagues as well. My practice is outpatient GI, and weight management is a part of that. Although what I like to do with weight management is I am the RMR person. So to me, I don't know how you do weight management without measuring resting metabolic rate. So I do that. And then I can follow patients, but I have a couple of people I like to refer to. I have a colleague who does some coaching. I have a colleague who has online programming as well. So I kind of like to be the person who starts it and then passes it on to the people who can provide the support. And I know all three of our panelists probably know how important that support is. I did want to mention that where I started with indirect calorimetry all those years ago was in critical care. And I cannot imagine doing critical care without indirect calorimetry. And so when I moved from critical care in the hospital to the home, I just was looking for, or outpatient home patients, I was looking for indirect calorimetry again. And I sure do love that the KORR is small and not big and hard to use. So I hope that helps with my practice.
Yeah, excellent. Thank you very much. Dr. Bailony, you're next on my little list.
Thank you for having me. Yeah, so my background, I'm internal medicine. I got fascinated by obesity when I was studying diabetes as part of a fellowship at Stanford about 6 years ago, largely around the concept of guilt associated with type 2 diabetes, and really wanted to figure out a way to navigate patients away from that, and discovered the OMA as well as other resources, and then went on to get my board. So I started my practice about 6 years ago. I would say the first year was really a lot of beta testing. I really had a passion to prove that we could do a chronic care model for obesity, so long-term patient engagement, long-term results. And so, one of the first things, because I was taking sort of this more beta testing type of approach, I think initially to my practice, I purchased a RMR up front and really used it to fine tune our program. And so we've been really, alongside the RMR as well as other technology, including a mobile app, we've really been able to engage patients long term. So our average length of engagement is over 24 months now. And our weight loss at 48 months, so at 4 years, is an average of 14.5%. So we've really been able to show that you can lose weight and keep the weight off. And now we're by partnering with other clinics, we're sort of growing our model. But the story short is definitely data helps in terms of fine tuning what you do, and we can get more into those specifics when the time comes.
That's awesome. Thank you so much. Jody, you're next on my little list. Tell us a little bit about your practice and what you do.
Yeah, so I work at Iowa Weight Loss Specialists. We are a multidisciplinary focused, team focused program here in the clinic I work at is in West Des Moines, Iowa. We are based out of a small rural hospital in North Iowa. The bariatric surgeon that's part of our program had been part of larger programs in the area and kind of hybrid a model for kind of what he wanted his program to look like. And part of that involves a heavy focus on medical weight management. And we also have a full mental health team as well. And so I've been with the practice for just about 4 years now. I see patients both before bariatric surgery, after bariatric surgery, and then I have a full medical weight loss practice. And the KORR indirect calorimeter, people who are in this field probably agree that most of our patients come suspecting possibly a metabolic problem. And so it's really nice to have that frame of reference. Another big deal that, another reason that I really appreciate having the tool and use it for is selection of medications. We have several different options, and based on the information from the calorimeter, for example, something like phentermine that suppresses the appetite. If someone, can eat 1,600 calories to lose weight. And, we all come with this nature of under eating and restriction. And so sometimes what I love about the calorimeter is I work in a weight loss office, and sometimes I get to encourage people to eat more, just saying, look here, this is your eating zone. And some people feel such great relief. I have people that are 6 foot tall and, 300 pounds thinking that the only way to lose weight is 1,200 calories a day, which is, sometimes I get to tell them, like, you should never eat less than 1,500 calories or something like that. So it's just such a helpful tool with not only assessment data, but then that patient education. The patients really sometimes are surprised or very, they're very insightful about that information. So very helpful tool in our practice here. And then before and after surgery too, when we follow patients over the long term or after, they've lost 50 pounds and they're ready to maintain their weight, maybe we will redo the indirect calorimetry to have that frame of reference and look at the changes that have happened and then directing maintenance or that sort of thing. So it's kind of another big tool with not only the initial assessment, but kind of that follow-up data as well.
That's awesome. Thank you, Jody. And then Dr. Morris.
Hi, everyone. Good morning to the panelists and those who are joining us as participants. My name is Dr. Morris. I practice primary care medicine with my wife, who's also a board-certified internal medicine physician. We have our own private practice here in Tucson, Arizona, and we both actually are board-certified in obesity medicine. And for us, the trip down obesity lane happened about a year or two ago, where we realized that a lot of our chronically ill patients obviously had a lot of weight issues, and just watching them kind of struggle and also hearing them complain and about the other, I want to say, like weight loss fads that they were into that weren't giving them the real results. So for us, it was like, well, I mean, we have the board certification, we know what to do. Why not build more of that into our actual primary care program? So right now we are 4 providers strong. It's myself, my wife, Dr. Backus, and we have 2 really good nurse practitioners, Gina and Marissa. And we have kind of built a team around practicing obesity medicine here in Tucson. So we've been using the review at least, I would say, for about 8 to 9 months now. On a more consistent basis, because I know once the pandemic hit, everything kind of slowed down.
Right.
So we're definitely getting back into it. And in our practice, just like Jody, just like Dr. Bailony and Dr. Jones have said, it does help kind of identify those patients who would benefit from all different strategies. And I think that kind of separates your clinic or your treatment plan from others out there who just want to dole out meds or just kind of do like a cookie cutter approach. We like the review because it kind of lets patients, it really shows them, okay, this is who you are, and here's what we need to do to fix. It's not a one size fits all. And I think for a lot of people, that's their concerns when they walk into a weight management clinic or practice, because they're just worried, okay, this place only does X. And I've tried that before, it didn't work. So with us, what we try to do here in Tucson is, at least in our practice, we want to make sure that when you walk in, we sit down, have the conversation, get the testing, and be able to tell you, Tom, this is who you are. Joan, this is who you are. So that way people feel at least a little bit more at ease following the instructions and committing to the plan.
I love that so much. Thank you. Thank you, everyone. And we've already touched on this a little bit, but I'm wondering if anyone would like to expound a little bit more on how they utilize the data from resting metabolic rate testing.
Well, I will just mention, I wanted to mention one thing too, as we're going along, is a very key discipline in managing weight is the registered dietitian. That would be me. Yesterday was National Registered Dietitian Day, so I know you all were thinking of me. But I think that each one of you have been really clear about how important food is with this. And so the registered dietitian is very important with that. But I also think that when we measure this metabolic rate, we give something objective. Kind of goes to what you said, Dr. Morris, is this is about you. So here you are. Even though it compares to predicted, I always say, pay no attention to that. That was, that's population based. Here's you. And to me, that is huge. I think we've all kind of said that, but I did want to point that out, that now I can tell you, this, I always tell them, now we're going to do diet according to you, because this is you. And I think that's a very important part of why I use it.
And Dr. Morris?
To add to that, I think the review also helps kind of, I want to say, dispel some of the myths patients come in with, where, I mean, I'm sure everyone here has heard, oh, I just have a slow metabolism. And then in your head, you'll be thinking, I don't know about that. Let's just see. And then when you can kind of objectively show them data, hey, you know what? Based on the pop data and what the machine is spitting out, you've done everything right. You followed the protocol to get the testing done. It looks like you're almost predictive normal on your metabolism. And it kind of gives them and I've seen it before, like really? So now it kind of gets them thinking more about, and going back to what Dr. Jones says, the nutrition aspect, like, okay, so now that we know that you're pretty much almost predictive normal on your metabolism, we can't really blame everything on that. So let's now put that in a box and let's work on the other aspects of weight management together. And you find a lot of them kind of, okay, and then they take a little bit more of a, concerted effort to make the changes, because now they don't have the quote unquote slow metabolism to fall back on. It's just that we need to change behaviors, and changing behaviors, it will take time. I mean, I don't expect anyone to today be one way and next day be another. So it's kind of a growth process that you as the obesity provider and the patient kind of go through together, and figuring out what works best for you. But to Dr. Jones' point, I love the fact that I can show patients, hey, you know what? Yeah, your metabolism is pretty much almost normal. Now, mind you, those who do have slow metabolism, that's an easy fix, because now I know exactly where to go and what to do, and then kind of reassure them, yes, it is slow, but let's see what we can do to get you where you can lose weight. And obviously we still plug in nutrition, because I think that's like 80% of what we have to do.
I'll kind of echo what Dr. Morris said as well, with, having that frame of reference. We do have a team of dietitians here. I didn't plug that in my first part, but we have, in my office here, we have 4. We have a fellowship student right now, so, or a intern right now as well. So it's huge part of our process here, and they give everyone typically the Mifflin St. George. They use that as kind of their calculation, and so sometimes even what we've given them in our baseline data, and kind of how I use it is, I'll typically do with my patients, kind of my routine is have them start out 2 weeks of a food journal and say, it can kind of be where you're at. If you want to start making some changes, great. Give me as many days as possible over the next 2 weeks. Then I'll bring them in for their second visit to the office and do the indirect calorimeter, and then compare, maybe where they're at to where they should be, and also kind of, we do kind of like the SMART goal setting here. And so if someone is, eating 4,000 calories and it says that they're supposed to eat 16 to 18, also kind of meeting them where they're at with, okay, I am not going to tell you to eat 1,600 calories tomorrow. Start out, maybe you've been journaling, you have some reflection now of calories. Let's shoot for 2,500 for a week or two, kind of gradually stepping down to really where they need to be. And that's a little less overwhelming. Everyone knows restriction. That's what they've been trying to do off and on for most of them their whole life. And so that's just where this can provide that nice frame of reference with specific goal setting and that sort of thing, to get them to where they need to be. And then with the Mifflin St. George, some of those that come back that are 20+% low, oftentimes those are the people who we're saying, you should eat 1,500 calories. And they're like, there's no way I can eat that much. I've tried to eat, and, people find this disconnect between you're telling me to eat more. And then it does come back, okay, you're really only supposed to eat 800. And, we do need to, stay within this tight range. So we do see some of those on occasion that it's very interesting.
Thank you.
I wanted to, go ahead.
Oh, no, go for it.
I was just going to mention that I have used my metabolic cart throughout the years in different studies, and we did study some patients who had bulimia. And so you may think bulimia is restriction and then purging, but a lot of time, or overeating and then purging, but a lot of times it's restriction. In fact, more restriction and overeating than the purging. And so time and time again, we've seen they've actually made their metabolic rate lower, even though one day they had 4,000 calories, the next day they had popcorn for 3 days. And so that showing them that has been very helpful. And also to Jody's point, getting people to eat again, and then showing them that they actually made their metabolic rate, quote unquote, normal, has been huge. And I think that Jody's made a good point also, that some of these people that are obese may go through a lot of 800 calorie days because they just think they should. And then day 4, they're like, well, that's it. And they go way off. So, right. And so I think that measurement and showing them, even if it is one that's lower than we expected, can be very helpful. Go ahead, Dr. Baloney.
Oh, thank you. Yeah, I would say we use the RMR in several ways. People have mentioned, as well as in some different ways. So in our practice, we have, many dietitians as well as many exercise coaches. So we focus on both nutrition and exercise. And so definitely agree that demystifying is a great use of the RMR, especially on initial intake. But the one thing is maybe from a different standpoint is, we do whole food VLCDs as part of our program, and we often get a lot of questions that, hey, is fast weight loss, I heard it's worse for your metabolism, Biggest Loser study, and we're actually able to pull our data on RMR and be like, actually, you know what, our data shows that people are not, their relative metabolism is not dropping if they do X, Y, and Z. And so that's really helpful. The other big helpful thing is we now also have been focusing a lot more on maintenance. And as part of maintenance, we look a lot at sarcopenic obesity. And one huge thing is sort of building muscle. So we're helping people lose weight, get the fat off, improve their diabetes. And then after that, we're actually focusing on a long-term approach to muscle build. And the RMR is very useful in terms of then knowing the exact calorie amount that a person needs and protein amount for them to really build muscle and lose fat while staying at the same weight. So we've been doing a great job there. So to give you guys some examples of that, like nationally average, if you look at if you look at studies, it shows that 25% of your weight loss is lean body mass. In our program, because of the way we've used RMR and making sure that the relative RMR doesn't drop, our average lean body mass is 8%, right? Which means that we have that much easier of a path on maintenance in terms of keeping people's RMR high. And so I always tell people that RMR and some body fat analysis, whether that's a DEXA or in-body, is sort of like the equivalent of what an echo is for a cardiologist who treats heart failure. You're not going to really know whether the weight biology is improving without looking at that, right? So if someone's RMR is no two journeys are the same. Losing weight and sustaining your RMR versus losing weight and improving your RMR are very different things, as well as obviously losing weight and having a lower RMR, right? And then that you need to focus more on maintenance. And so we try to get everyone doing an RMR 3 times a year, and we really use that to fine-tune their program. From that standpoint, it really does help us improve things. So, for example, studies have shown that a VLCD plus cardiovascular training versus a VLCD plus resistance training. So in the former one, you lose weight and your relative RMR goes down, even though you lose more weight. Whereas if you do the right type of resistance training, you can actually do a VLCD, which is 800 calories. You can fully restrict yourself. Your RMR will actually go up relatively based on studies and based on some of the testing we've done here. And your lean body mass will only drop a hair, and that's on 800 calories. So the limits of what the human body can do can really be fine-tuned and made much more precise with an RMR machine. And that's actually why, from a company standpoint or from a provider group standpoint, a lot of people are going to exclusively telehealth, and we've taken the approach of trying to team up with different locations to place an RMR and an in-body, because we do feel like it helps with from a precision medicine approach. And so that's one of the ways we use it. And then on a more practical approach, I know some people have mentioned lower RMR. And so what do you do about a low RMR? Let's say someone comes in and they have a low RMR. There's 3 ways you look at that. The first thing is you compare it to an in-body. Do they have a low amount of lean body mass, which is a lot of people do. And so if that's the case, what you need to work on. You need to work on building muscle, right? Number 2 would be a hormonal problem. So you're looking at thyroid, you're looking at adrenal insufficiency, and you want to make sure you catch those things. The last thing is for patients who are on thyroid medications, you can use an RMR to titrate their medication, as long as obviously it's within symptomatic control, and that can be really helpful in terms of really where you should be with your thyroid dose. We have to remember that thyroid averages on labs are averages across a population, but where a person was before they developed hypothyroidism is personal. So for example, my average TSH could be at a 1, and then I develop hypothyroidism and my doctors are treating my TSH to be at a 2. Well, that means that, my body's not used to that level of thyroid and needs a little bit more. And so the RMR can actually help you figure that out. And you can literally titrate a person's medications to that middle zone, obviously making sure that you don't cross the boundaries of evidence-based medicine on the free T4 side of the equation. And then the last component is, what about the person whose RMR is low and there's no reason for it? Well, with those folks, there's a lot of interesting things, but one, it's not a problem for weight loss. I've usually always been able to get people to lose weight, but in terms of weight maintenance, it's a tougher journey. So I use that to explain, hey, this is why you should consider obesity medication. It's because you're walking a hill uphill and everyone's walking flat, and it's not fair. So, you should use this medication. It's gonna help, it might not help your RMR improve, but it's gonna help the other processes that govern weight improve, so that at least the scale is more equal. And so I would say that that's the last way to use RMR from, hey, is your RMR low?
That's good stuff. Yeah. Thank you so much. So we've talked a lot about how you've been using RMR testing in general. Can you talk a little bit to the pandemic? Can you explain why it's continued to be effective, and if it's helped you in any way throughout the pandemic? And just as a note to our listeners, each of these people, Dr. Bailony is obviously from California, which has been really tightly shut down. And we have representatives from Iowa and Texas and Arizona. And so this will be really interesting to get all of your perspectives on how the pandemic, since the pandemic is affecting every area of the country differently. I'm curious to know how RMR testing has helped you through the impacts that you've seen in your practice.
Yeah, I can actually take a stab at that one. So pre-COVID, even though we obviously have a telehealth platform already set up, our visits were 75% in person, about 25 or 28%. It was about 70-30. Telehealth with 30%, 70% was in person. And after COVID in December, that was 92% telehealth and 8% in person. And all the in-person visits were all metabolic testing. So frankly, and for one of our locations here, we built out we literally broke ground on a new construction on the day the shelter in place got announced. And to be honest, it was a very stressful, time in terms of the investment that was made there. But the RMR really allowed people to come in on occasion, as well as the in-body, and see the new location and at least use it from that space and time. And our RMR testing surprisingly grew in 2020 despite COVID. So we actually grew our RMR revenue by 27%, 27% year over year. And so it did allow for an in-person feel. It allowed us to see our customers on occasion, even though everything else was done online. So I think if it wasn't for RMR, gosh, no one would have used the office at all last year. So it's a good thing we had it.
Well, for me, I very well remember I think it was March 12th or 13th, I did my last RMR in the office, and then we got the news, dun, 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 no more. And so I started to do telehealth visits. And after about May, many of my visits were, I don't know why I've gained weight. Something has happened. I have been doing the same thing I did before. And so then, and thank you to Julie, who sent me something that I put in my office that I posted that talked about how the review works and how there's no rebreathing, et cetera. So I posted that. I did require masks coming into the office and after the test, but I have been able to continue with the RMRs. And I think people wanted to know. It was actually, again, one of those things where you actually may have done less and eaten more when you were home, even though it didn't seem like it. I mean, not running through the airport for me changed my metabolic rate, I'm sure. So, but I wanted to tell you also that I love a very nice, fancy body fat measurement. But I also love the old-timey skin fold calipers and have spent a lot of time with those. And in fact, a study we did, which validates what you said, Dr. Baloney, that resistance exercise makes a big difference in weight management. We used our calipers to measure body fat. And so you can use the old stuff. It still works. You have to be really good at it. So you have to practice, but I use that in combination. I also wanted to mention that in the study that we did, it was presented at FNCE in 2019 and will someday be published again, but I was very surprised to see metabolic rates lower than expected in men who were overweight and obese, not morbidly obese, because our study cut off at a BMI of 35, but the women were pretty close, but the men were much lower than expected. And over the 6-week period of working out and eating, they didn't do very low calorie diets. They did a diet equivalent to their RMR measurement. Their actually RMR improved and they lost weight. So it was very interesting. And so I believe that really points to the fact that we have to be multifactorial in weight loss, that exercise has to be a part of it as well.
Mhm.
Well, for us, we definitely took a hit during the whole pandemic lockdown here in Arizona. So because we couldn't get anybody in, and I mean, and we get it, because like all the other practices, we had to transition, because we're primary care primarily, so we had to transition more to a web-based telemedicine platform. So, and getting patients to come in, especially when, you know, a lot of the patients we have in Tucson and Arizona are on the older side. I mean, when I say older, I mean like decade 40 to 70. So either they work or they were out of work because of being furloughed, or they just didn't want to take the chance. So, I mean, for a few months, I mean, we kind of were just down on this. We kept doing what we were doing through, you know, the health coaching and just the virtual visits. So, but as of the last, I would say maybe 3 months, we're picking back up again. People are getting, I think they're realizing the COVID-19 15 is real. So now they kind of want to get back into, okay, I fell off the wagon. What do we got to do? So we're getting them back in to get retested, obviously, to see exactly, okay, after this last year, what's been going on, you know, because a lot of people are complaining of lack of physical activity because, one, they're doing the Zoom thing for work all the time and they're not getting as physically active. And also the break room is now the kitchen. So they spend a lot of time, you know, opening up the pantry, you know, and just staring, and a lot of mindless eating, which we're seeing. So for us, yeah, it did take a huge dip, but now we're seeing it build back up, especially now that things are opening back up and people are becoming a lot more aware, honestly, of the link between obesity and COVID-19 severity. So I think people are, if there's one good thing, or one of the few good things that can come out of this time that we've been through, is I'm hoping people get more aware and more in charge of their health, and not just leave everything to chance. Because, I mean, the study after study shows that people with the chronic diseases linked to the chronic disease of obesity don't do as well if they get, you know, infected by the COVID-19 virus. Mm-hmm. So, I mean, that is one thing I think hopefully puts the population or the public on a path to better health and better health, sorry. And we're here to help.
Excellent. Thank you.
You know, I wanted to mention something because you said it, Dr. Morrison, maybe you guys can make a comment on this, but in COVID, I went to several lectures, many on non-alcoholic fatty liver disease, and the connection between obesity and NAFLD is breakable. It's and medications, no medications, the best, well, I say no medications, but medications are difficult. The best treatment is what we've described here as lifestyle changes and weight loss. And I actually had a patient that I saw, and she came to see me because she was obese, and that was okay. But when I said that she had in her data, it said non-alcoholic fatty liver disease. Oh, suddenly it was important. Being obese, well, you know, okay, yeah, I know, I'm obese, but that NAFLD made a difference. And to your point, Dr. Morris, knowing now that the effect of the COVID causing more challenges to the obese, maybe this is helping us to understand, helping our population to understand it might be reasonable to seek out help.
Thank you so much, everyone. I've got one last question to hit before we turn it over to the Q&A. And that's, we have a lot of people here who are either considering RMR testing, or they have RMR testing equipment and they're trying to figure out how to implement it. Do you have any advice for doctors regarding the value of RMR testing or regarding implementation strategies?
I think you have to advertise that you have it available. and that and what it means. And then second of all, for practices, I do my own metabolic testing because I do it as a part of a consult. So it's part of a 1 hour consult with me. But in a practice, these are pretty specific practices that are amazing, but it could also be done by a technician who could just understand how to do that, because the thing about the review is if it's a bad test, it will tell you. I had a patient who had a study guy who had been through for 9 minutes. He was almost finished. He took the biggest breath I've ever seen. And we went on again for 10 minutes. I think I called Julie and said, what happened? He kind of reset the machine, and 10 minutes later he was done. But so a technician could have managed that. So I think it could be to me, a selling point. And it's an important test if you're measuring, if you're doing weight management. And Jody mentioned Mifflin St. George. That's good, but that was 500 patients in the 80s. We might be different now. So that's where I'll end it.
So one key takeaway I would like, those watching who are considering getting it or who have it and haven't really begun to use it as well as they would like is education. You just have to get out. And I mean, social media is huge. Everyone's on their phones as it is. So going out and just doing your own videos where you kind of talk about what it is. And what I did initially when we got it, I actually did my own test and I did a video and I went through my own results on the actual review. And I posted that to our Facebook page. And I mean, I think that kind of let patients see, okay, so this is, and I actually said, okay, this is me. Here's where I'm not doing too well. Here's where I could be doing better. So, it's for one, it kind of gives patients that sense of, okay, so, I mean, if it's good enough for him to do on himself and to discuss his own results, because I mean, I didn't make it look like I was a superstar, it definitely was, more real for me to do it that way, I thought. And I think people responded to that. And so it's all about education, because I mean, you can have all the major devices and the awesome stuff in your office, but if people don't know it's there or how it works, because it's available, no one's gonna come through the door or even think about getting it done. So for those out there, I mean, it's fairly easy. The way we do it in my office is that you get your 1 hour consult, and then what we do is we set you up for the actual body comp, RMR, and EKG if needed, and blood work within a week or two of that initial consult. We use the first hour to just basically get to know you, and and go through our questionnaire to see where you're at, what's worked, what hasn't worked, where you would like to be, just to kind of get to know you, so you're not feeling rushed, and that's just our process. And it's delivered by one of our technicians here, and then it's reviewed by myself or my wife, Dr. Backus here. Or one of our nurse practitioners, and then we kind of go over the results, and then the plan is built. So it's a fairly easy. I mean, I think we haven't had anyone complain. We have had, to Dr. Jones's point, a couple erroneous tests, and after doing some digging, when I went back in the room, you find out that, oh, that's right, I had a cup of coffee at 4 this morning. I'm like, oh. We asked the questions for a reason, Yeah, but I forgot. Yeah, I woke up at 4 and had a cup of coffee. Okay, so we got to redo this whole thing. You got to come back another day so we can get it done again. So, but it's all about education and getting the message and the knowledge out to the patients. Hey, this is how it's used. Here's how it can benefit you.
Is there really anybody who doesn't want to come to your office with the lights down and rest for 20 minutes?
I don't know. Breathing into a tube is not is not always the best experience.
That's the next 10 minutes. The first 20, they're it's a great benefit.
My only 2 cents on the last question is, you definitely want to make it part of your program, not an optional. I think if you're going to use RMR, you do have to be structured about it, right? So going back to the point I made earlier, if someone comes to you with acute decompensated heart failure and you put them on an ACE inhibitor and and a beta blocker and aspirin, you're usually repeating that echo 6 months later to see, and 1 year later to see if the heart has started to remodel itself. And similarly, you want to sort of have a standard approach with RMR testing so you can see from a weight loss perspective if the plan needs to be changed, if the body is improving, and as well as an educational point. The one thing I forgot to mention that we use RMR for is, alternate day fasting has become a very popular way to either maintain weight or lose weight. But if you look at the evidence for alternate day fasting, on the fasting days, you should be at 25% of your RMR rate. And so I don't know how a provider can prescribe alternate day fasting without an RMR. I think it could be it's so different from person to person that you got to get an RMR before and then give that person the calorie goal on that fasting day. So I would say that's another way we use RMR for maintenance or program start. So you got to make it part of your program. You got to make it part of your approach. I do think that this is easier to do for people who are focused primarily on obesity. I do think, and coming from a primary care world before this, that obviously there's a lot to do in the primary care perspective. So making sure that there's someone at your site who is fully focused on obesity or managing obesity helps, because it goes a long way, I think, given the busy nature of primary care these days.
Well, thank you so much. We're going to go ahead and toss it over to Tim. He'll go through the questions that have been coming in and ask them to the panel.
Perfect. Thank you all. We do have a few questions that have come in. Again, as you have questions, feel free to click on the Q&A button and type in your questions. The first question is from Amy Coopersmith, who asks, how do you use the initial RMR data to set calorie goals? For example, if the RMR is 1200, should the goal be greater than 1200, or can you try a VLCD with resistance training and monitor?
Personally, when I get my RMR, I don't use VLCDs. So what I do is if the RMR is 1200 calories, then that's my first place that I set it. I will also try to get an idea of their activity. And so, we go from being very exact to saying, okay, well, about 30% more calories is what you do for activity. So then just trying to get a separation point so I can tell them they're saving 300 or 400 calories a day or 200 or whatever. But I use the RMR. I don't use any VLCDs. So Dr. Bailony might have more data on that.
Yeah, Dr. Bailony, do you want to speak to that? Because I have heard over the years practitioners indicate that if you're going to use a VLCD, then why do you need to know the caloric intake or their energy expenditure? So your take on that.
Yeah, that's a good point. One is even though I don't use it anymore because our practice got too big, but there used to be, the NIH used to provide this great weight loss estimator, which takes into consideration a lot of factors, including your initial RMR. And actually, if you plug in a VLCD into that, you can almost to the dot get a prediction of what the patient's journey is going to look like. It's pretty cool. So you could use it in predictive analytics. And for most of us practitioners, it's not practical. I no longer do that. But the biggest thing you have to remember is that you are interested in what happens, the change in RMR. As a matter of fact, I would say the change in RMR is more important than the initial RMR. The change of RMR is everything we're trying to either avoid or improve or optimize. And so you got to get an RMR at the beginning so that when people lose weight, you're doing it the right way, so you can improve your VLCD, so you can make sure people are lifting weights, so you can show them that if they can get up to 4 sets of 10 exercises 3 or 4 times a week, they can not lose any RMR, not relative RMR. And so I would say that's that. The other thing is in terms of concern about suppressing someone's calories too much, I would say there's no evidence to suggest that. We can look at studies across the board. And yes, there are definitely some studies that show that people that do a VLCD or fast weight loss may have a more pronounced deficiency in relative metabolism after, but actually there are other studies that show the opposite. And so then the question is what explains the variability between one study and the other? And I would say that the variability is probably explained in those small things about the program that are not in the study details, right? Whether people are placed on vitamin D, whether resistance exercise is encouraged, whether people are on whole foods, whether that those foods are high in fibrous vegetables, and so those differences are not often like scripted in the studies we read. So I think the best data is your own data and your own practice and adjusting it and titrating it. And that's, so yeah, I don't have any concerns about doing a VLCD. I've done 800 calories on people with an RMR of 4,000. And, when they get out of a VLCD, their RMR is not 4,000, but it's where it is appropriate for their new weight. And so it hasn't dropped significantly. So, I think a lot of the concerns around fast weight loss, if you really look at the data, is as long as it's done right and it's done in the right way with the right protein, with the right supervision, you probably can get better results long-term taking that approach.
Excellent. And I'd like to toss this over to Jody also. I think as our representative from bariatric surgery patients, I think it's a similar question. How do you use RMR when the calories are going to be determined by their postoperative prescription? Do you have any thoughts on that, Jody?
Yes. So with bariatric surgery, we have kind of the timeline of 800 to 1,000 calories, 1,000 to 1,200 calories. We do only do the gastric sleeve procedure here, so I just want to set that as a disclaimer that this is not representative of gastric bypass or other bariatric weight loss procedures. We don't typically do the RMR until in some cases we do it before surgery, but then we don't typically do it until the patient has plateaued or is ready to maintain or those sorts of things. So the patients are usually about 9 to 12 months out, at least from surgery, before we'll do an RMR, unless there's a major mismatch that happens shortly after surgery where we deem it necessary to determine medications or kind of adding things up with what the patient's telling us and what our recommendation will be. So yes, so I've had cases where, for example, I had a gentleman that he and his wife both had surgery. They own a restaurant, so he's on his feet running around from 9 in the morning until midnight. He runs a DJ business on the weekends, and so he pretty much 7 days a week is very, very active. And he was to the point where he was losing more weight than he wanted to. He had dropped below 200 pounds, and he's like, I'm done. And I feel like I'm eating all day. And his wife, on the other hand, is a couple years out from surgery, still measuring 2 ounces of turkey and half a cup of cottage cheese. And he's eating the cinnamon roll she makes and still losing weight. So that was where, that individual is able to eat. His metabolic rate is where he can eat 3,000 calories a day and maintain his weight. So in that sense, of course, the sleeve is designed to be restrictive. So you're still going to have a portion restriction over the long term. And most of our patients, that was a kind of an extreme example. But sometimes we just kind of take it into consideration with the patient of, okay, this is saying that you could bump up your calories a little bit. And if patients have the room, because we do see appetite creep up, at that 9 to 12 month mark. And usually if they've incorporated more exercise, that sort of thing, it's appropriate for them to eat a little bit more, but defining that and giving them the evidence of exactly what that means, because eating a little more could mean like 200 or 300 calories, not 800 or 1,200 more, so giving them that frame of reference, like, yeah, you should still be able to lose or maintain your weight in this, range. So.
Excellent. Thank you, Jody.
Perfect. Our last question is, How can we tell patients the test is safe during COVID?
I use the information that I received from review. So if you guys haven't received that, you can certainly receive that. But I always have kind of shown them how I wipe down the equipment. I've always shown them that the rebreathers come in a plastic container that are in wrapped, so they're first time use for you. I always explain how the air goes out. So I've always done that because I've always thought people might wonder about this, like where are they getting the air, et cetera. So I've always explained that. So for me, just having that little disclaimer that I put next to it that, by the way, nobody seems to care about, but they really want to know their metabolic rate, but it's available. So I haven't had anybody concerned. I'm more the person who tells them what's going to happen and why it's safe. So that would be my answer.
Same experience here with myself. We just explained, but yeah, but to Dr. Jones's point, I haven't seen much kickback since, people are able to come out in terms of like real worry about the virus. Because I mean, people, they kind of want to figure out and get to know, okay, what do I need to do to lose the weight? So, but I mean, the informational pamphlets we have go through all that stuff and and even what we tell patients, hey, this is how we do it. This is what needs to be done. And this is how clean it is. This is how the valve system kind of works. I mean, it doesn't take more than a couple minutes to just explain, but haven't had anyone walk out because they didn't trust it. They just, okay.
Agreed.
That's good. It's
Yeah.
good to know.
Yeah.